So why do we have numbness? So what is numbness? It seems sort of funny for me to ask that question, but I have to tell you, I'm always surprised by people in my office who don't really know what I mean by numb. What do I mean by numb is that things don't feel normal. There is decreased or absolutely no sensation. All right. And people will say to me, well, why do you think I'm numb? I have really bad arthritis, they might say, or I really can't move it very well, and that's why it's numb. Or they'll say, it's paradoxical, it hurts a lot, but I think it's numb. Bottom line is that when you have pain, it can be from anything, right? It can be because you have a bruise. It can be because you have a broken bone. It because you have a pinched nerve, because something is hot. So lots of things can cause pain. Same thing with stiffness. You can have stiffness because you had a trauma, or maybe because you have current arthritis. You can have weakness. Yes, that can be from a nerve, but that can also be because you're deconditioned. Atrophy is when we see wasting away of your muscles. And again, although from time to time that can be neurological, like if you've had a stroke, it can also be from disuse atrophy, and maybe not just because you're lazy, but because you have arthritis around a joint and you're not moving something very normally, and that's going to give you wasting of the muscle around that joint. But the one thing I can tell people is this: if you are numb, I know it's neurological, because that's the only thing that gives you sensation. So I think the best way to start talking about why am I numb, for me to explain it in a way for everybody to understand, is to understand that when we talk about nerves, what are we really talking about? Think of nerves as live wires. And the way it works is that live wire starts at your brain. It comes, and then it comes out of the base of your skull in the form of your spinal cord. That spinal cord then comes down your back, and along the way, nerves exit your spinal cord through the bony creaks and corners of your spine, and then different branches will weave together to create these big named nerves. And those nerves are then going to go to muscles, skin, or your organs. If they plug into your muscles, we call them motor nerves. If they plug into your skin, we call them sensory nerves. And although most nerves start out being a mixed bag of those things, by the time they get to the very end of the road, they're one or the other. So again, starts at your brain, and motor nerves start in a different place than sensory nerves. They try that brain now creates their spinal cord, which you can see is the central yellow line here. And then what happens then, if you take a look at this little gray man here, he's got his gray brain, he's got a spinal cord at B, and then you'll see at A where a nerve is coming off of his spinal cord and going down his arm. So when we talk about a nerve, this is the pathway that we're talking about. That nerve now has to get down into your arm. And how does it do that? Well, it comes off your spinal cord. It just can't magically leave your spinal cord. It has to sneak its way out between the bones of your spine. If you look at the x-ray on the left, you'll see that there's spaces between your bones, and those actually aren't spaces. Those are where your discs are, right? So it's not a space at all. And if you look at the arms off to the side, that's all part of your bones of your neck, but they're not solid. All right, they're not solid. We're going to talk about that in just a minute. But again, we said the nerves come off of your spine, and then they weave, like you see on the left here, and then they end up with your named nerves. And then, as I said, those nerves continue on their way down to your fingertips or down to your muscles. There's just one important difference. You can have a damaged spinal cord or brain and still have reflexes. All right. So when the doctor taps on your knee in the office and your knee jerks forward, that nerve simply goes up to your spinal cord and goes right back down to your knee. It doesn't involve your spinal cord itself or the brain. And that's why we call them reflexes. It's also why you might have a numb hand, i.e., you don't feel the heat. But if you were to touch something hot, your arm would reflexively come back if you have certain kinds of nerve damage. So reflexes are different than the nerves that we traditionally think about. Now, there's different kinds of damage that can happen to your nerves. There's mechanical and there's medical. I'm the mechanical girl, right? I'm a surgeon. If you have a medical neurological problem, that's what we generally send you to a neurologist. And these are terrible, terrible diseases like Parkinson's or ALS. Or from time to time, you can have damage due to non-neurological disease. Neuropathy, if anybody here is a diabetic or has severe thyroid problems, you may have been told that you get diabetic-induced neuropathy. Or you can have damage because of medications like chemotherapy after you have cancer. So those are medical reasons, which I, as a surgeon, really can't do anything for. And unfortunately, those need to be managed from a medical perspective if they can be. On the left side of the screen, you see the mechanical sources. Something's being physically pinched because of normal tissues, or there's scar due to abnormal tissues. Nerves can be cut, or there can be pressure on them from a tumor or a mass. So going back to your neck for a minute, we talk about these bones. If you look on the side, they're all stacked on top of each other. The yellow markers here are where your discs are, and the red lines in the back are joints, all right? Now, why is this important? Well, because this is where your nerves can get pinched in your spine. Look at your spinal cord. That's that flesh-colored yellow surrounded thing on the right side. Now, I bet you didn't know this, that your spine is hollow. Well, maybe you did. Your spinal bones are hollow, and through the back of them travels your spinal cord. But because your spinal cord is sitting in that spot, you can herniate one of those discs out, like you see towards the bottom, the blue thing pushing out and squishing against the spinal cord. You could have bone spurs from arthritis, and that's that red spot in the middle where there's arthritis off of one of the bones in the back of your neck. You can have bone fractures. You can just imagine if one of those vertebral bodies smashed and those bone fragments pushed backwards up into your spinal cord, how that could be painful and also cause neurologic damage. And then, of course, there's always tumors, both in your bones as well as in your spinal cord. And this is what I meant by hollow. When we looked at our x-rays here, it looks like there's a stack of bones that look solid. Well, if we take those bones and we turn them 180 degrees and we look down, you'll see that there's something called a vertebral foramen. That is where your spinal cord sits, and that's what you can see on the left. On the right side, what you can see is your spinal cord is in the middle, traveling down this stack of bones in this hollowed out tube. But for the nerves to get out, they sneak out between each of these stacked bones. Think of them as stacked logs, and your nerves are trying to squeeze out between the edges. So, of course, that's another place where nerves can get pinched as they leave your spine between these bones. And again, that can be from herniated discs, or those can be from nodules. So even before we get down to, outside of your neck area, I have lots of reasons for you to have a numb hand. Spinal cord injuries, spinal cord compression, or nerve root compressions. Now, we also talked about that once those nerves come off of your neck, they bob and they weave. And if you look at the left screen here, and you don't mean to look at this detail, but just the idea that all these nerves are these large nerves that come off of your spine, they weave together. I like to call it macrame. They macrame together to form these big nerves that you see coming down your arm on the left side. Those nerves that you guys all think of as your median nerve, which is your carpal tunnel nerve, your ulnar nerve, which is a different nerve that goes to your pinky, or your radial nerve. So because these peripheral nerves that come off of your cervical spine are combinations of others, we give them names like we just talked about. Well, where are they? Where do they get pinched? Well, to give you an idea, this is your arm. Do you see any nerves? I don't see any nerves. Well, you know why you don't see them? Because they're all underneath the muscles, right? So now it's not necessarily bones which are squishing your nerves, but just as your nerves bob and weave between these different layers of muscles, and as you move your muscles and they muscles scissor against each other, that can cause compression of your nerves. What are some of the symptoms if those nerves are being pinched? Well, burning pain. Almost everybody who has nerve pain describes that pain as being burning pain versus a sharp or aching. It's described as burning. Numbness, which is what you were all looking for today. Weakness. Again, those muscles don't just plug into your skin, they plug into your muscles. And so after a period of time, you will actually get weakness because that nerve's not plugged into the muscles anymore. And then, of course, because your nerve's not plugged in, the muscles will actually start to waste away or give you atrophy. Now, as a doctor, I very much appreciate that these named nerves have pretty consistent functions and patterns, right? Which is why I need to take a good history. I need to get from you, what's your pattern of your numbness or your patterns of good sensation? And if you have weakness, where's that pattern of weakness? Or if I can use my eyes and look at you, see what muscles are wasting away, because I know what named nerve goes to each of those different muscles. And that helps me figure it out. So as you can see here in these arm diagrams, the one on the left is the palm side of your hand, the one on the right is the back of your hand, and you can see that hot pink, well, that's where your radial nerve goes to give you sensation. So if you tell me that you have numbness on the back of your hand or on the back of your thumb, I'm kind of thinking that you might have a radial nerve problem. Or if you have numbness on the palm side of your hand to these three fingers, I'm thinking, ooh, you probably have carpal tunnel. We see an awful lot of that. But if you tell me that your pinky finger gets numb, I'm going, oh, well, that's probably a different nerve. That's the blue nerve or the ulnar nerve. Now, things get a little tricky here because although that's the main way for me to judge your numbness, remember we talked about those nerves coming off your neck? Well, they can get pinched there. And because that's before they all weave and macrame together, if you have a pinched nerve in your neck, that's a different pattern of numbness. That's why I torture my patients and go, are you sure it's not your middle finger? Are you sure it's your ring finger? And they look at me like I'm crazy. It's my damn hand, doc. Why do you care? Well, I'll tell you why I care. Because all those branches that we talk about that macrame together, well, that carpal tunnel nerve is made up of branches from the fifth cervical spine, the sixth, the seventh, the eighth, and even the top of your thoracic spine. Whereas your ulnar nerve, the one that goes to your pinky, is just a mixture of two nerves sort of the bottom of your spine. And your radial nerve is also a mix of all these things. So when I see certain patterns of weakness or numbness, I know that it's probably more likely to come from your neck because that's the pattern of numbness. We call those dermatomes. And so right here, if you take a look here, the top picture is if you pinch the nerve at your neck, what goes numb. And on the bottom picture is if you pinch one of these peripheral named nerves, which fingers go numb. And again, it's my job and your primary care job, doctor's job to figure these things out. But that's why we torture you. And that's why before you go to the doctor, the next time your arm goes numb, before you try to shake it out or make it not be numb anymore, stop and really pay attention. Wait, which one of my fingers actually does feel numb? Because it really is important and it is very, very helpful for the doctor. So that when we take that good history from you, we have already a clue as to are we looking at the neck, are we looking at the arms? And if we're looking at our arms, where in your arms are we looking? Then, of course, the doctor has to do a good physical exam. And although I love telemedicine as much as the next person, why? I hate telemedicine as an orthopedic surgeon, but I understand its benefit. But it's not really, really helpful when someone comes to me for neurological stuff because I really, really need to see both arms, both hands in real light. I'm looking for wasting away, shininess to your skin. I want to touch you. I want you to tell me, oh gosh, I didn't realize that finger was numb, or gosh, I didn't realize I could feel on that side of my finger. And for me to figure that out, I actually have to touch you. I can test your strength. And I don't mean like big stuff like can you lift things heavy? I mean, I test very specific muscles. I can test your biceps versus your triceps versus your brachioradialis versus your abductors and your adductors versus your thenar musculature. And by doing those tests in my office, again, I start to get a clue. Does this look like it's something being pinched up high, or does this look like something that's being pinched down low? And again, where is it being pinched by all these things? I can also put you in provocative positions and say, hey, does this make it feel worse? Or, hey, does it feel worse when you hold your cell phone? Or, hey, does it feel worse when I make you bring your chin down? Those are also clues for me. Now, if I'm really concerned and I'm not very, very happy with my physical exam, or I feel like I've still got some questions, I may order some tests. And one of the tests I may order is something called the nerve conduction study test. Another is called an electromyogram. Imaging, if I'm pretty sure that your pinched nerve is outside of your neck, I don't need imaging. If I think your pinched nerve is in your neck, or I'm not sure it might be in your neck, then I will absolutely get x-rays or MRIs to look at that. Also, if I think there's a possibility that your nerve is being pinched by a mass or a tumor, then I might get an ultrasound or an MRI. But most of the time, by and large, if you have numbness and it falls in one of the classic patterns, we don't really need to get any of those imagings. Now, what does a nerve conduction study test do? A nerve conduction study test is kind of what it says. It measures how fast, if I stimulate your nerve here, how fast does it get to here, okay? And we measure that in milliseconds. And we know what it should take, what a normal is. And if it takes too long to get from here to here, between here and here, well, then I know there's something at your elbow causing the problem. So again, that's what a nerve conduction study test does. An EMG, well, that stimulates a muscle. That sees how well is your nerve working plugged into your muscle. I always say a muscle is like a lamp with a cord. If you pull the plug out of the wall, I don't care how many times you flip the switch, the light won't go on. Think of the cord being plugged in as being the nerve, the power source for your muscle. A muscle is just a muscle. It has no power unto itself. It's a lamp that will work when you plug it in, and the plug is the nerve. So again, when we do EMGs, we're measuring how well is that plug working as it innervates the muscle. And again, as I said, if I am worried about something in your neck, then I'm going to get x-rays to start with. And then I probably will get an MRI. And an MRI is lovely because x-rays only show me the bones. The MRIs are going to show me soft tissues as well, like discs, as well as your spinal cord itself, as well as your nerves. So it's very helpful for showing us herniated discs, as well as tumors, as well as also showing bone spurs and things like that. But heading down into the arm, all right, when we talk about these peripheral nerves being pinched, what are we looking at? Well, first thing I like to talk to my patients about a little bit is something what I call the drowning man analogy. Because people will say to me, well, is it really, really bad enough that I need to have an operation? And I'll say, well, think of a pinched nerve as a drowning man. And the analogy I say is if you walk around the corner and you see a guy kneeling on the floor with his head in a bucket of water, very much like this gentleman here, you do not need to be a surgeon to know that you should take his head out of the bucket of water, right? And if somebody asks you, why are you taking his head out of the bucket of water? You'd say, well, because he's not breathing. And if he's not breathing, his brain's not getting oxygen. And if his brain's not going to oxygen, he's going to die, right? We all know that. No, we've seen people on the beach. We know about the drowning man. But here's the thing. If you walked around the corner and that guy had just put his head in the bucket of water and you took his head out, he'd be no stupider than he was before he put his head in the bucket of water. If you walk around the corner and it has been, let's say, 3 minutes since he put his head in the bucket of water, but you know how to do CPR, you can probably get him back, but he's probably not as smart as he used to be. And if you walk around the corner and it's been an hour since he put his head in the bucket of water, you can't bring him back. I don't care if you're the most brilliant neurosurgeon in the universe, you can't bring him back. There's now been irreversible damage to the nerves in his brain. Why? Because we all kind of understand intuitively that the longer that your brain goes without oxygen and nutrients, permanent irreversible damage occurs. Well, guess what? When you feel numbness somewhere, that means your nerve's not getting the nutrients it needs, which means your nerve is drowning. And so it's not 2 or 3 minutes. But there is with nerves a continuum of damage where at some point some of that damage will become irreversible until it's completely irreversible and that nerve cannot come back. So that's my drowning man analogy, and that's what we keep in mind when we talk about addressing these nerves and how aggressive do we have to be. So carpal tunnel, everybody and their mother has heard of carpal tunnel. What is carpal tunnel? Carpal tunnel is the #1 diagnosis that I, as a hand surgeon, see in my office. And my understanding from my primary care colleagues, they see a fair amount as well. Carpal tunnel is the most common cause for hand pain, and it is due to a pinched nerve at your carpal tunnel. Everybody has a carpal tunnel. It's just in some people it's too tight. And because it's too tight, the median nerve, or the nerve that runs through that carpal tunnel, can't function properly. And so the sensory that it provides, which is the thumb, the index, the middle finger, and even half of the ring finger, the first sign of it is intermittent numbness to those fingers. For a variety of reasons, it usually bothers people at night when they're lying flat, which is why many people tell you that by holding their arm up over their head or shaking it down below the bed, that it will make their hand feel better, all right? But it's a thumb, index, long, and half of the ring finger that gets you numbness. And again, this is compression at your wrist, all right? And this is what it looks like as that nerve comes down your neck, as we talked about. What happens is it has to get into your hand through this tight little spot on your wrist. So this is why we talk about wearing a carpal tunnel brace, because it keeps you from crimping your nerve or stretching your nerve as it comes from your forearm into your hand. And so that's why wearing a nighttime brace is the first line treatment for carpal tunnel. Unfortunately, if you don't get any better with using of a brace, then we certainly have an alternative of doing a surgical procedure where we physically release that tunnel. You can see that picture in the circle, that little band sitting on top of your nerve, that can be released surgically. And that is a definitive treatment for carpal tunnel. Why do people get carpal tunnel? There's certainly a heredity factor. There's repetitive use. A lot of women get it in their pregnancy, but it goes away when their hormones settle down. But then, of course, conditions like diabetes and rheumatoid arthritis and thyroid dysfunction can also kick in and make it worse. Cortisone injections, people ask me all the time about it. Cortisone does not cure carpal tunnel. It may resolve the symptoms temporarily, but there is a danger to putting a needle in somebody's carpal tunnel. And on top of that, there's also a danger of putting cortisone around your nerve. So although it can be a diagnostic process, it is not meant to be therapeutic. Now, cubital tunnel is a pinching of the ulnar nerve, and it's the most common cause for your pinky finger and the other side of your ring finger for going numb. And that's caused by ulnar nerve compression at your elbow. All right. Now, this is the inside of somebody's elbow. You'll notice we're looking at the pinky side of their hand. So this is on the inside and through here, right at your funny bone. Well, it's not so much a funny bone as it is your ulnar nerve. And again, if you see here, there's a term there called cubital tunnel. And you'll see the ulnar nerve as it travels, that thin little line that's traveling underneath the cubital tunnel ligament behind your elbow. So that can be irritated simply by resting your arm, like when you're driving your car for a long period of time, on the window or on the console in the middle. It can be aggravated at nighttime if you're watching TV with your arm bent because you're stretching the nerve. It can be bothered as you're working at home on your computer with your arms resting on the arms of your chair. I had a lot of people during COVID get cubital tunnel. I told them, take the arms off your chair, and their cubital tunnel went away. And it can also because at some point you had an injury and your nerve is actually so loose, believe it or not, the paradox, so loose that it's popping in and out from behind your elbow, and that can irritate it as well. Risk factors here: obesity, as well as repetitive bending and stretching, leaning on it, or having to hold your arm bent for long periods of time. And again, the management around this is if we can modify your activity and make you better, fantabulous. Sometimes wearing a splint at night to keep you from sleeping with your arms all coiled up like this, because that'll stretch your nerve. Believe it or not, unlike carpal tunnel, sometimes if the nerve is just a little inflamed from these activities, we can get it to calm down with some therapy. But again, unfortunately, ultimately, these often do require surgery to take the pressure off of the nerve. And when we do surgery, we have two options. The one is on the left, where we simply open up the tunnel and then the nerve stays right where it is, and that's about a 40-minute procedure under a general anesthesia. But sometimes after I do this release, the nerve is now so loose from me releasing that little band that in the OR, when I bend your elbow, that nerve goes from the back of your arm to the front of your arm, to the back of your arm, to the front of your arm. And I know you're not going to like that. So then we have to do something called a transposition, which is after I open the sheath, I have to then move the nerve to the front of the arm, and that becomes its new home. So that's called a transposition. Now, Guillain Canal syndrome, this is frequently a cause from a mass. When we talked about nerves being, why is my hands numb? Well, it can be from a mass. Well, in Guillaume's, this is that same nerve at your elbow, but after it travels a little bit further down your arm, and now it's in the palm of your hand, actually next to, not in, but next to your carpal tunnel. And in fact, if you'll look at the picture here, you'll see here is your carpal tunnel right in through here, and there's your ulnar nerve. So this can be pinched. This can be pinched often by a mass, like a lipoma or a ganglion. In fact, that's so common that if you come in with numbness to your pinky finger and the nerve's not irritated your elbow, I will get an MRI of your hand, even if we can't feel a mass, because I need to make sure that that's not what the problem is. If it's not, then we can release it just like we do a carpal tunnel. But the flip side of that is if I find a mass, the answer is not just to open up the canal, but we need to get the mass out of there. Usually these are benign tumors, by the way, ganglions and lipomas, but still it's like having a pebble in your shoe. We got to get it out to get rid of the symptoms. Radial nerve. This is a very unusual syndrome, but I always like to bring it up so we talk about this third sensory nerve. The radial nerve starts up, again, we all talk about up high in the neck, and as it comes down your arm, it actually branches into two branches. One branch goes deep into this muscle and then emerges on the other side simply to give you sensation onto the back of your hand. It doesn't innervate any more muscles. So for people, and you can see how it travels in this little wedge of a space right here. So that nerve can be trapped anywhere along its path underneath this muscle. Particularly people do a lot of twisting type of exercises. So maybe you are putting together some furniture from Home Depot or from, what's that big place where you have to put in 17,000 screws, right? Do a whole day of that, and all of a sudden you've got some burning on the back of your hand and some tennis elbow, by the way, right? That can be Wartenberg's. And this usually does get better, but not always. Now, the second place that this can get pinched is, if you look at the bottom of your screen, is this nerve then continues on down to the wrist. So anything that pinches your wrist tightly. Sometimes we'll get prisoners from the prison where the handcuffs were on them for a really, really long time. Or as the cops say, they were trying to get out of the handcuffs, which is why it wasn't the cuff that was too tight. It was that the person, they just stopped fighting the cuff. They would have been fine, but they rub, 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 rub. Now they have this numbness on the back of your hand. So again, this can be scissoring from the muscles rubbing on each other, or it can be from an external source of compression that can give you some numbness on the back of your hand. If it's a handcuff issue, take the handcuffs off. If it's a problem with the muscle, very, very, very rarely, 2 times in 25 years of practice have I actually had to do surgery on that muscle to take the pressure off of the nerve. And that leads us to cut nerves, right? Because if you have numbness and you had a cut, it could be that you cut your nerve, right? So the thing is about cut nerves, and this is a take-home lesson I'd like to have from people today, is if you cut your nerve, I have a limited window of time to fix it. You know how we talked about those nerves starting up at your brain and then traveling down your arm? Well, what happens when you cut a nerve or cut a nerve? The 2 ends of the nerve retract. Why? The one that's on this end is all the way attached up to here, and it actually will pull back. Now, the end that goes further out into your hand is now dead. It's like cutting your hair. The part that's still attached to the roots, you could argue that that's kind of a lie, but what you cut off, this is now dead. It's no longer attached to anything. So wherever you cut the nerve, from there down, the nerve is dead. Can't do anything with it. It's absolutely useless. But it's in a tube. And that tube will guide a new nerve to grow down its pathway, but it can't do that unless I surgically, mechanically put those 2 ends together, which is what you see us trying to do here. So this poor fellow went through a plate glass window and cut his median nerve. All right. And again, kind of hard to see, but the idea here, he cut his nerve right there, and there's the other end. I have got to go in there and put the 2 tubes together. Just to say again, the tube from here down is dead. He has no sensation to any of these fingers because he cut the tube. I now have to sew this nerve to that end, and then the live nerve that started up in his brain will grow, 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 grow. All right. But there's immediate numbness. And that's my other take-home lesson. If you cut yourself and you have numbness, don't wait for it to get better. It's not going to, unless it gets fixed. It will not get better. So if you have numbness after you cut yourself, you need to see a hand surgeon within 3 days. You don't need to see it the same day. You probably should go to the emergency department, get it washed out, get a couple of stitches just so you're not bleeding all over the place, so you don't get an infection. But you need to see the hand surgeon within 3 days. Why? If over the next 3 days the numbness goes away because it was just some superficial nerves, not a big nerve, great. But if it doesn't, that hand surgeon has to evaluate you, talk to you about what can be done, and get you on the OR schedule within 10 days of you cutting your nerve so that they can do a repair. Because otherwise the 2 ends pull too far apart and a repair or a primary repair can't be done. Now, we can graft it. That doesn't work nearly as well. So again, if you cut yourself and you have numbness immediately, go to the emergency department, get your emergency treatment, but understand at the end of the day, you need to see your hand surgeons if we're going to take care of that nerve. So in conclusion, numbness is from nerve damage, always, always, always. And that nerve damage can be mechanical or medical. You can start off with your primary care doctor to figure that out, or you can stand off with your local orthopedic surgeon. Nerves can be damaged anywhere along their path, anywhere from all the way up at the spinal cord level all the way down to the tips of your fingers. And the way we figure that out is by taking a really good history from you, doing a really good physical exam, and occasionally also doing some mechanical testing. Help us help you. Think about your patterns of numbness. Think about your patterns of thinkness. Think about what positions or postures make it worse. Think about if you had an accident before it all started. Think about if you had a recent change in your activities that precipitated that numbness, because those are all very useful clues to help us get to the bottom as to why is your arm numb. And again, take home lesson, if you have numbness after an open injury, please, please, please see your local hand surgeon within 72 hours. And if you have chronic numbness, remember that drowning man. Don't wait until that numbness is constant, because that may mean that the damage has become irreversible. Not necessarily, but it becomes a possibility, and none of us want you to be there. So thank you very much.